Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Sreenadh Gella from Birmingham, United Kingdom. Dr. Gella is an hand upper limb surgeon at the Sandwell and West Birmingham NHS Trust. He was appointed as consultant in upper limb and hand surgery in the trust in 2016 after his completion of a Canadian upper limb and hand reconstruction fellowship. His primary interests are in sports-related soft tissue injuries of the upper limb, and he has published in a wide variety of top-notch journals, including the Hand Clinics, Instructional Course Lectures, Journal of Hand Surgery, Journal of Orthopedics, Knee Surgery-related research, etc. He actively participates in research and has taken part in the draft trial as well as the WIDE study. And he's currently doing research trials with the PROFER2, which is nothing but the proximal humerus study. And also he has some research interest on the olecranon fracture tension band suturing technique. So today, it's my great honor to introduce you to Dr. Sreenadh Gella from Birmingham, United Kingdom. Over to you, Sreenadh.
Hi all, my name is Gella, as I was introduced, and today I would like to talk about the spaces of hand and acute infections. Before we go any further, I would like to keep it very simple, very basic, and I would like to stick to the topic in such a way that if you know about this, if you listen to this, it is easy to pass your exam, FRCS Orth, especially in the Viva and clinical scenarios sections. So before we go any further, the spaces of the hand, these are the potential spaces. What I mean by that, as you all know, if you open a hand and if you want to have a look at the spaces, they are not available unless there is a pathological collection that is present there. They only become obvious whenever there is a collection that is present, and whenever there's an infection, or whenever there is sometimes when there is a tumor, or when there is a reactive effusion that is noted. All these infections usually start initially as cellulitis, and either they can go in two ways. If our body is strong enough to resist the initial infection, it may disappear from cellulitis stage, and there could be an induration for a few days and it may disappear, or it may end up as an abscess or a collection. These infections are very common among those patients who are immunocompromised or have any other coexistent medical problems. I would like you to have a quick look at this picture. The reason why we are going to have a look at this picture is that all these spaces that we are going to talk in a minute are completely potential, and they are lying quite deep in some cases, and some are superficial. If you look at the hand spaces, some of these spaces like pulp spaces or web spaces or dorsal subaponeurotic and dorsal subcutaneous spaces, these are all quite superficial. The flexor sheaths, radial bursa, ulnar bursa, mid-palmar spaces, thenar spaces, and hypothenar spaces, these are usually deep. And if there is an infection there, usually it takes some time before it becomes quite apparent that it is not cellulitis, it is not a superficial infection, but there is a collection. Few things I would like you to keep in mind from examination point of view. Usually whenever they present these cases, to make it easy for you, they start giving an introduction where they give a history where there's a patient is diabetic or an IVDU to give you a bit more clue towards going for a deep-seated infection. The most common pathogen for these conditions is Staph aureus. So whenever they put an X-ray or whenever they put a clinical photograph, usually there is a white collection that is present there just to make it easy for you. The other things, if they are giving an information of a human bites or animal bites, there are these can usually human bites can have eye canala. There's got whitish green type of tinge at the time if it is discharging, and Pasteurella multicida, it is a bluish green type of tinge that can be present if there is a pus that you can see. The most common growth for animal bites is polymicrobial. Please have a look at it. If you have a look, as you can see, the typical history that they may give you if they put this patient in front of you or a clinical photograph in front of you, saying that this guy is a 50-year-old patient who was working at his workplace, and after that he noticed a small sharp sting in his index finger, and later on he came to us with this presentation. And what do you think? What are you suspecting? And how do you proceed? The typical question will be like this. It won't take us for as long to find out that it is a flexor sheath infection looking at it, but it all depends on how we say that it is a flexor sheath infection, what words we use, and how we proceed will make you either a pass or a borderline pass or a super pass. So before we go in detail about how we handle these scenarios, we need to know that majority of these flexor sheath infections are penetrating injury or from a contiguous spread of infections from surrounding tissues. Indirect spread is possible but uncommon. One thing that we all need to know in the variation of anatomy is that I don't know whether you all can see my arrow. This is the most common variation where the little finger flexor sheath is connected with the ulnar sided bursa, followed by the ulnar and radial sided bursas are connected with each other. So these are the two most common variants that we can see. The importance for this is that whenever you put this one, whenever they say this case is there, always tell them that you are going to examine the hand and also forearm for any contiguous spread of the infections. We all know about Kanavels signs, but if they put a hand picture like this, things that are expecting for you to read is that if you tell them that it is a sausage-shaped swelling and finger is in flexion position, and in this scenario, as you can see, there are two bites that are there. This is a patient secondary to a bite injury, and you can say that it is a penetrating injury, and with this attitude, and so you are worried about flexor sheath infection, and you would like to see whether there is any tenderness on the flexor sheath or pain on passive stretching to rule out Kanavels signs. And if it is positive, it is very highly suspicious of flexor sheath infection. As we are all aware that these sort of cases cannot be put on your clinical examination, as these are acute cases, and usually they put a photograph for you to talk about it. Coming to the treatment part of it, the treatment, yes, we can give a non-operative treatment in the form of IV antibiotics for early infections. There are publications regarding them, but if the common practice is that whenever there is a suspicion of flexor sheath infections, to avoid late complications and also severe stiffness, the preferred option of treatment is incision and drainage and washout. There are two ways we can do it. Either we can do a acute washout, or like this, we can do a continuous washout in the ward where there's a collection that goes from the other side, and for about 24 to 48 hours, later on it can be taken out. The one thing that I would like you to remember is that the complication rate can be up to 30 to 40%. These include stiffness, recurrent infections, need for further surgeries, or scar problems. Like as I was mentioning before, if we go back and recollect our photograph, usually they give some information about this patient, and usually the information about this case would be going like this, saying that the patient is a 45 or a 50-year-old with who had a previous problems of diabetes, If you can see that photograph, you can see that there was a subcutaneous purulence, and if there is any human bite or a dog bite marks that are there, and if there is any blueness at the tip of the finger, you can say that there could be digital ischemia. All of them are very poor prognostic factors. Usually, in your exam scenario, when they put these photographs, they'll make sure that at least one or two of these characters are clearly seen on the photograph, and they would like to see whether you can pick those findings easily or not. The other way you may find the infections is that they may put a patient with a late complications, and this can come as a clinical question for you, where the infection has settled, but the patient may have a old tendon rupture. And in that scenario, with a lot of stiffness, and in that scenario, you have to start initially with wait for, if it is a pure stiffness is the problem, the treatment modality is to give at least hand therapy for about 6 months. And this hand therapy comprises of passive and active range of movements for about 6 months, and see whether they can make it better. And also, if at all, if after six months, if the symptoms are not improving, if the stiffness is persisting, we can consider for surgical release of the adhesions. But the results are quite poor. I did about 2 of them, and one patient did not have good results, and the other was happy enough to have a decent range of movements. So early operation always is better, and late complications are very difficult to manage. Tendon necrosis can happen, and sometimes even though you control the initial infection quite well, there can be avascular necrosis of the tendon, and there can be late ruptures as well. If these happens, we need to consider for 2-staged reconstructions, and the results are in general are quite poor. As I was mentioning, sometimes these flexor sheath infections have got continuity to either the ulnar bursa or radial bursa and space of Parona. And whenever these infections spreads there, it is a surgical emergency, and we cannot treat it without any with non-operative treatment. The ideal treatment options comprise of a carpal tunnel decompression and also the decompressing the infection. Luckily, these are not very common if the patient presents earlier, but if the patient presents late, you commonly see them, and long-term outcomes of these are not great. In the same area, when we are talking, this is one of the other things that may be put in front of you. As you can see that there are some streaks of lymphangitis streaking that are present, and with a cellulitis and with a scab around it. Whenever you see this, it's predominantly secondary to the streptococcal infections. Usually there will not be any collection. So in this, if they put this one, yes, you can suspect any underlying collections, but always tell them that you are going to examine the fingers, and you are going to make sure that there are no other collections there before you consider for any incision and drainage. Please do not jump in for a surgery for these sort of cases. Deep Palmar spaces, these are the 3 most common spaces that are there, and majority of the time, if you have any questions, the questions will be surrounding these spaces, collections surrounding these spaces. And I would like to start with the Thenar space. Oops. Sorry, I think, okay, let me start with pulp space. Pulp space injuries are mainly because of the inoculation, and as we can see, the thumb and index finger are the more common ones, and increased compartment pressure in the pulp can cause necrosis of the tissues there. And whenever there is a pediatric pulp space injury, when they put it there, always mention that it is very highly likely that there can be osteonecrosis. Therefore, you're not going to wait for it to settle by simple antibiotics, and you will have very low threshold to take the patient to theater. In neglected cases, it can spread to the flexor sheaths, and One question that you need to understand here is that usually they put a glove in their hand and they ask you to put an incision, and they'll ask you to show what sort of incision are you going to give for these patients. And whenever you're giving the incision, please have a look at the next slide. You can give either the first or the second one. Try not to put either any part of this one, either a fish mouth or a U-shaped, or the other one you need to avoid is a H-shaped, which I don't know whether you can see this. Yeah, the H-shaped incision or a two parallel incision, try not to give it. These two are no and no, and these two you can give it. And the first one is my preferred incision because the results are quite good for these patients. So deep Palmar spaces, there are three deep Palmar spaces. The first one is the Thenar and mid Palmar and Hypothenar. The Thenar space is bounded, as you can see, the by the medially by the mid Palmar septum, and towards the radial side, the lateral septum. It's an imaginary septum here. It's a very thin layer that comes on this side, and at the volar aspect, the fascia covering the adductor pollicis, and dorsal aspect, it is fascia covering the adductor pollicis, and the volar aspect, you can see the flexors going to the thumb and index finger. So the collection at this space, as you can see, is the most common collection that can happen. And it can go distally to the first web space, or proximally it can go to the flexor retinaculum. There are some certain things that I would like you specifically know about it. A Thenar space infection, usually they put an a clinical photograph like this. If they give it like this, it is always much more easier and giving away the features. Usually the typical type of photo they put for you is which I'm pointing out on the left side. The things for you to remember here is, number one is the thumb will be in an abducted position and the fingers are going to be straight. And there will be a collection here, or there is an induration here. So if the thumb is in abducted position and the fingers are not curled up, it is a Thenar space infection. And usually the swelling is more predominantly on the volar aspect than on the dorsal aspect. You'll know in a minute why I'm emphasizing these three words. One is the thumb in abducted position, finger straight, and the swelling is predominantly on the volar aspect. So the role of non-operative treatment in these cases is minimal, and early operation, early surgery gives better results. The incisions, usually, as I told you, if they're discussing with you, the examiner wears a glove and he asks you to put an ideal incision, what you think is right. Either you can go for a single incision. If you're putting a single incision, you can put in volar, and you can put a double incision. If you put a double incision, you can go for the dorsal one and a volar one. That's up to you, depending on the collection and depending on the size of the abscess that they put. But one thing that is important is that try not to connect these two in the same incision. So try not to take it volarly and try not to take it dorsally. So that can create troubles for you. So the mid Palmar space, as we have shown before, this is the mid Palmar space. If you look here, there is radially there is a mid Palmar septum, and ulnarly there is hypothenar septum, and volarly, as you can see, the fascia that is covering the intrinsic muscles, and on the volar aspect, you'll see all the tendons that are going for the little ring and middle fingers, and the deep palmar arch and superficial palmar arch are present. Proximally, it extends up to the carpal tunnel region, and distally to the web spaces. So last time, few minutes back, we were discussing about the attitude of the fingers and hands for the thenar thenar collection. In the mid palmar, there are few things that are quite giveaway in your clinical practice or in the examination photos. If you look here, usually the fingers are curled up and thumb is an adducted position, and the swelling is more predominant on the dorsal aspect. So if you see these things, it is most probably it's a mid-palmar abscess. And whenever you are considering either a mid-palmar or thenar or hypothenar, you can always tell that you would like to take an urgent ultrasound scan and MRI scan. Nobody is going to pin you down for that, and you can proceed. Or whenever you are saying it based on clinical judgment, it is a thenar or hypothenar, and if there is any collection, patient is not getting well. And if you say that I have a very low threshold of taking him directly to the theater, if the examiner tells you that there is no access to the MRI or ultrasound scan at the place where you are working, and what would you do? You can still take them to theater and explore it and wash it out. That will give better results than leaving it alone. And the hypothenar collections, hypothenar space, throughout my almost 4 or 5 years of consultant as a consultant hand surgeon, and also previously doing 2 years as in my fellowship, I've seen only one case. I think I can say that it is a hypothenar collection. These are very rare, and majority of them, even if they present, they are very vague, and usually if they present, they present with pain on moving the little finger. So the only question they may ask you about this one is that where would you give an incision? The incision is usually in line with the radial aspect of the little finger and the proximal aspect, and you expose it and you decompress it. And the collection is also be, even if you open it, last time when I opened, or when I was speaking to my mentors who have done a few more than me, they were saying that they hardly find any pus. They get collections which is very diffuse and indurated. The other one for your exam scenario is that this is one of the structure you would like to know, and I'm pretty sure you all know about the basic structure of the nail bed. Any area can have an infection in and around, and it can cause paronychia. And the things what you need for acute paronychia, you all know what is the treatment. But I would like you to know more about this chronic paronychia. There are two things that you need to say is mainly candidal and the cause is candida and fungal in origin. And the treatment options are marsupialization. As you can see, marsupialization means, I'm pretty sure you all know, they take a piece of U-shaped tissue at the base and they excise it. And the other technique that we can use is for Swiss roll, that is open it up, roll it up, and suture it so that the base is exposed and the infection is cured at a later time, and you can release it later on. Herpetic whitlow, I do not think you'll be asked about it, but if you want to know, it has got multiple bulle type of appearance at the base of the nail, and the nail plate is not very bad, not much affected. If the nail plate is affected and there is some pigmentation underneath with a recurrent pain that is coming, and the base looks completely normal, always your first differential diagnosis should be Glomus tumor rather than the chronic paronychia. This is the typical appearance of the chronic paronychia, where there is no, as you can see, that there are changes that are present at the nail bed, and with the nail looking deformed, and the features that are going in chronic paronychium would be a longer duration of history, and on top of it, as you can see, there will not be any acute collections or acute discharge that you can see. And sometimes there will be telltale features of this patient having the problems with the other nail folds as well. So the other thing that may be asked is a web space abscesses. These web space abscesses are important in your exam for the purpose that you need to tell two things importantly. One thing is that the attitude of the fingers, wherever the web space abscess is there, the two fingers are kept in abduction. This differentiates from the dorsal subcutaneous collections. Whenever there's a dorsal subcutaneous collection, usually their fingers are in adducted position, whichever fingers those are affected. And whenever there's a web space abscess, it will be in abducted. So if they're showing two X-rays with two pictures with these two findings, you must always say based on the abduction whether which one is your first differential diagnosis. And the favored one is a two incision technique. One incision goes on volar, one incision goes on dorsal. Sometimes you can connect both of them and put some you can put a wick until the collection and everything settles for the next few days. So this is the typical incision that a majority of the hand surgeons prefer. You can, if it's a predominant collection is on the volar, you can give a single incision, but majority of the papers nowadays, they support more and more of two incision technique than a single incision technique. So I would like to welcome any questions from you guys, and I would like to have any feedback if possible, please.
Thank you, Dr. Gella, for that fantastic presentation. You've covered almost all what is required for FRCS. And this is going to be like a takeaway, take-home part of infections. Just a few questions. There's something called as a dumbbell-shaped or hourglass-shaped swelling that can occur in the wrist, isn't it? If you have, suppose it's tuberculosis or something like that. Correct. So is that scenario common?
So whenever you have, in this one, as you can see, predominantly I covered the acute infection part. For a reason, I did not go and touch the chronic infections. So whenever there is a dumbbell-shaped swelling or dumbbell-shaped infection that is present around the wrist, going from the wrist to this thing, it is predominantly because in the middle there is a flexor retinaculum, or there is a constrictive band that is there, wherever it is. So that can cause this dumbbell-shaped swelling. Whenever it is present, the differential diagnosis must be either tuberculosis, as a rheumatoid synovitis that can cause the similar sort of things, or any other chronic conditions, like even very rarely you can present, it can be a sarcoidosis or other chronic polyinflammatory conditions that can be present. Usually with acute conditions, if they present, they are secondary to a contiguous spread from flexor sheaths going down and going into the other areas. And so far I faced a patient only once. The results are quite bad if it is spreading so fast and spreading into the space of Parona and going there at dumbbell-shaped and marking like a horseshoe-shaped swelling.
Thank you, Dr. Gella, for that. The other question is, whenever you see a swelling in the mid-palm as well as on the dorsum of the hand, can you say that from which space does it occur? Is it coming from the thenar, mid-palm, or the hypothenar? Is it technically possible? Is that a diagnostic clue to say which space does it originate from?
This is one of the things the examiners are looking from you. Okay, as I mentioned before, whenever there's a collection, let's say that is in the thenar space. I was mentioning that the thenar space collection is present on the just superficial to the adductor aponeurosis. Sorry, the adductor muscle aponeurosis. Okay, so because of that, it is an abducted. For comfort, if they curl the fingers, it will be very painful. So for comfort, patients keep all the fingers straight and thumb abducted. And if we look here, because of the adductor muscle and everything is stopping it, all the swelling will be predominantly on the volar aspect. Contrary to that, if the swelling is coming in the mid-palmar space, because of the swelling there, we want to create more space on the volar aspect for comfort. So the patient keeps all the, including thumb in adducted position to give more space there, and also fingers curled up. That is a big telltale feature if they put that clinical photograph. And because they are putting it, and the dorsal aspect of it, usually there is a lot of reactive effusion that is present, and there will be a swelling on the dorsal aspect, even though there is no collection. So I should have put some MRI scans. Previously, we got it in our trust, and I could not get permission from the trust. So whenever we do an MRI scan for these things, you can see a lot of subcutaneous edema and volar collection for them. So if you see a clinical photograph with fingers curled up, dorsal swelling, and palmar swelling, and keeping the adducted thumb, you can say that my my impression is mid-palmar space for these reasons, and the examiner will be very impressed.
Okay, thank you for that. That was a very, very important point, like what you mentioned. And the location, if you find it on the dorsum, it also points towards the mid-palmar space. The other one was the collar stud abscess or the collar button abscess, which is commonly said. No, now what is a collar button abscess? What do they imply? Is that a small lesion there?
So if I go back here, this collar stud abscess is because of the web space infection. So if you look in between the two web spaces, the two metacarpals are attached to each other by these ligaments, intermetacarpal ligament. On top of it, this natatory and other ligaments go between them, and they prevent the spread from one to the other. So in other words, there is an abscess at the bottom, there's an abscess at the top, which you can see like this, like I call this thing, and in between them, there is no spread of the abscess. So if at all, either if you release it on the volarly or dorsally, you are not going to get the complete clearance of this infection collection. So that's the reason why what my, or no, not mine, it is the preferred approach is to make volar and dorsal incisions both, and putting a wick through it, and going through, if possible, going through one of the ligament and going to the dorsum, and clearing it for a few days.
Okay, thank you, Dr. Sreenadh, for that. Just one last question before we wind up. See, at one point of time, there was a role for a continuous suction irrigation. I mean, irrigation and suction. What is the current concept? Is it followed now, or is it completely outdated?
It all depends on which unit you are working in. So the continuous suction irrigation is commonly followed in UK in some of the units where there is a plastic surgeons are practicing it. Do not ask me why that is. And if there's an orthopedic surgeon's hand unit, then they try not to follow that method. So even in our hospital, we have two plastic surgeons. One of them does continuous irrigation for this flexor sheath infections. If you look in the literature, there is no literature that supports either of the practices. You got plenty of evidence that is supporting either of them, and there is there is no evidence saying that one is better than the other. And but only thing is that it is quite tedious because you must have a good system to do it, and you must have the trained staff, and also a very majority of the patients who they should be listening to us to say that they have to stay in the bed. And as you are aware, majority of the hand patients are quite funny sometimes, so you can't trust them. So if there's an IVDU guy comes with a flexor sheath infections, you put it there and if it disappears from the bed, it is your headache. So that's the reason why majority of the places they don't want to do that.
Okay. Thank you, Dr. Sreenadh. I think that's all the questions that we have for this session. Thank you for joining in. Fantastic lecture. All that you need for the FRCS with respect to hand infections, you've covered all of them wonderfully. Thank you for joining in.
Thank you. Thank you.